Hi, everybody. We're going to get started. I'm Catherine Pearson. I'm the Director of Communications here at ISR, and I want to thank everybody for joining us today for the fall kickoff of the ISR Insights Speaker Series. For those of you who might be new here, the Insights Speaker Series has been running for about 4 years now and highlights research from ISR faculty in interesting topics relevant to our society. If you're interested in attending future talks, we have a full schedule of our upcoming talks, as well as recordings of all of our past talks on our website, isr.umich.edu. The recording of this talk will be posted sometime next week in that same spot. Just a quick housekeeping note, we'll save a little time for Q&A at the end, and we'll come around with a microphone. So think of your questions and save them for after the talk. And today it is my distinct pleasure to introduce Dr. Julie Maslowsky. Dr. Maslowsky is a developmental psychologist and population health scientist who studies adolescent health with a focus on sexual and reproductive, reproductive health, including contraception and abortion. Today she's here and will review the disproportionate barriers that young people face to accessing contraception and abortion prior to the Supreme Court's decision in Dobbs v. Jackson, and how the landscape has shifted since, and what we know about the impact of policy changes on adolescents' health and well-being. And so now, without further ado, welcome Dr. Maslowsky.
Thank you, everyone. It's such a pleasure to be here today. I actually trained here at ISR as an MSW and PhD student. So I was here for 8 years, and then I'm so glad to be back now as faculty. I joined in January, and this is my first talk back. So thanks for welcoming me back. What I will attempt to cover today, I'd like to do an overview of trends and current status of both abortion and contraception in adolescents, how the landscape has changed, and what we know so far. It's early, data take a while to come in, as you know, but what we know so far about impacts on adolescents. There are a lot of data limitations when it comes to studying these topics with adolescents and minors in particular. So I'll talk about that and a research agenda we recently put out that tries to fill some of these data limitations. And then I'll just tease, because our project literally started 8 days ago, but we have a new project that I think would be of interest to folks, where we're creating a data dashboard of state policies that we hope will interface with a lot of the data that many of you all probably use. So, as most of us, all of us know, on June 24th, 2022, the US Supreme Court ruled in Dobbs v. Jackson that there is no federal constitutional protection for a right to abortion, meaning that states were able to decide whether and under what circumstances abortion would be permitted. This is a map that's current, at least as of a few days ago. There's a lot to keep track of, but this shows that since then, 22 states have either fully banned or imposed gestational limits on abortions. And then I wanted to give you a sense of trends and where we were in terms of number of abortions prior to Dobbs. So this is 2012 to 2021, and it's 3 different measures of abortion. So we have the top line, the solid line is raw number, the heavy dotted line, the middle line is a rate, which is per 1,000 birthing people, and then a ratio is a ratio of abortions to live births. So you can see all 3 were trending down a bit at the beginning of this, so 2012, but by the time we get to 2021, all 3 were trending actually up a bit. And so the question then is, what happened after Dobbs? You would think half the states are no longer allowing abortions or are restricting them. You would think the number would go down, right? So this is the current best effort to track number. This is raw numbers of abortions monthly. This is an effort by the Society of Family Planning, and so they actually are attempting to count, like contact every facility and count number of abortions being done in the country. And so as you can see, this starts in April 2022, so a couple months before Dobbs, goes through March 24. We have not seen the decline that you might expect. The yellow and orange that they introduced toward the right, they're starting to get very interested in tracking whether abortions are being done via telehealth, and whether states who are in providers who are in states that have shield laws are providing to patients who are out of state and living in a state where abortion is not legal or is limited. And so once you count those, you can see that the best estimate is that maybe number of abortions have even gone up since Dobbs. And abortion is seasonal, so you have to look at it month compared to month last year. And but even if we did that, we can see that maybe we have a slight uptick, if not holding steady. Then I wanted to shift to adolescence and give you a bit of perspective here. So here I have 3 trend lines from 1973 to 2023. And in this case, this is 15 to 19-year-olds because that's the way that CDC likes to group it. We'll talk later about age groupings and their pros and cons. But so we have the orange line on top is number of pregnancies, the blue line is number of births, and the green on the bottom is number of abortions. You can see that among teens, these were trending down. The blue line goes through 2023. As I said, we have data limitations, so we don't always get data stratified by age, but both pregnancies and abortions were trending down. We don't actually know what's going on with adolescents currently in terms of numbers. As I'll tell you, we know that births are still going down, right? We don't know what's happening in terms of pregnancies and abortions. And adolescents do face a lot of barriers to accessing abortion, but pregnancies are down. So we're not sure exactly where those trends are and hoping that some of those data will become available soon. This is prior to Dobbs. This is adolescent, and it's the abortion ratio, so ratio of abortions to live births by state. And so this is pre-Dobbs, so 2017, well before Dobbs. You could see that we have tremendous state variation in the abortion ratio. The states are small, so I'll tell you, New York, New Jersey, Connecticut, DC are some of the higher ones on the right. Kentucky, Arkansas, Oklahoma, and South Dakota are some of the lower ones on the left. Does anyone know what red indicates here? Yes, I see a hand. Yeah, exactly. So they didn't have it at the time, but those are states that now have bans. So what we can see is that in states that now have bans or limitations, abortion rates were already low. So access was difficult already for teens prior in those states already. But also I would pay attention to the state variation here. Later I'll tell you about our state policy project. So states really vary in terms of their policies and in terms of the access environments. So that's really important. Geography matters a lot here. Adolescents in this pie chart are the peach and the green. So they make up about 10% of abortion patients, and they have the highest abortion ratio of all age groups. So there is a demand among pregnant adolescents for abortion procedures. And so we have some ongoing work because there's just so much we don't know, especially about minors and abortion. So we have some ongoing work just estimating what proportion of minors live in restrictive states. I've got asterisks because we're still under review and in prep with this, but our guess is it's over half. Over half of US adolescents are living in restrictive states. Yet, if you look at the research done on abortion among minors, again, our not quite peer-reviewed estimate is 3% of studies even include minors. And that doesn't account for those that most don't stratify. So minors are in the sample but aren't analyzed separately. So we really have very little evidence specifically on minors. And all sorts of research about abortion, whether it's predictors of, consequences of, experiences during, minors are vastly underrepresented. Yet we know that they face disproportionate barriers to accessing abortion care and disproportionate impacts of restrictions. And of course, among minors, historically marginalized groups are the most impacted by restrictions. On the right, I have an op-ed that we put out on June 26th, so 2 days after the ruling, calling this a major problem for minors and outlining the barriers that minors face to accessing abortion. And that was pre-Dobbs, and those have increased. I wanted to couch my remarks in reproductive justice, which is a framework that guides much of the work that I do. So this is a theoretical framework that was developed by a group of Black feminist scholars in the 90s. The current most common definition is that is put out by Sister Song Women of Color Reproductive Justice Collective. And that is that reproductive justice is the human right to maintain personal bodily autonomy, choose when and how to have children or not, and parent in safe and sustainable communities. So as many of us may be aware, there's a real tension between, in the past, there's been a lot of approaches that have felt a lot like population control. in this type of work, and population control disproportionately aimed at people of color, at marginalized groups. And so in our field, we are really working hard to embrace reproductive justice, to embrace free choice and person-centered care, that people have the right to have or not have children, to use or not use contraception. So that is very much the place that my work is coming from. Reproductive justice builds on the intersectionality framework, which is, of course, from Michigan's own Kimberly Crenshaw. Intersectionality says that many of us live, or all of us really live at the intersection of interconnected social categorizations that are overlapping in interdependent systems of how we are treated, many of the times systems of discrimination or disadvantage for those of us who have marginalized identities. And so for youth experience a system of discrimination called adultism, which is prejudice and systematic discrimination against young people. In this country, if you look at the way that rights are legislated, youth have many fewer rights than adults, making youth a marginalized identity. And then within the larger category of youth of color, of low SES, and other marginalized groups are going to be disproportionately impacted as we layer multiple marginalized identities. Reproductive justice is an incredibly broad framework. It is much broader than just reproduction. So it explicitly recognizes historical injustice in a number of systems. For example, we know that the field of gynecology has an extremely racist history, including medical experimentation on people of color. And so bringing forward that this is the history and that we have to do better and that we have to improve our practices. It really beautifully articulates ties between multiple societal challenges. For example, police violence and reproductive autonomy. If we see on the right, her sign says all mothers were summoned when he called out for his mama, George Floyd. It integrates both individual level and structural level determinants of health. So for example, we might think about individual rights, but also contextual safety, health, and law and policy, all of which produce systems that individuals are working within. And it centers and promotes both intersectional and anti-racist solutions to these problems. And so, as we think about adolescence in these multiple contexts of identity, of systemic discrimination, of fewer rights than adults, some of the barriers that we have identified that adolescents either disproportionately or uniquely face, one includes travel. So think about adolescents. Many of them maybe don't drive or don't have their own car. Most private carriers restrict minors' travel. So Amtrak, buses, flights, planes, most have pretty strict policies about who can travel and requiring parental consent to travel. And we know that a lot of people are traveling for abortion care these days, and minors are restricted in their ability to travel. Payment for travel is also a challenge. And increasingly, we're seeing new laws being introduced that are trying to interfere more with adolescents' ability to travel out of state. So these laws are nicknamed abortion trafficking. That is a phrase that they use in the laws. It's not really a thing. But so this shows Idaho's law. And so they created a new felony called abortion trafficking, which means that anyone in the state of Idaho who assists a minor in obtaining an out-of-state abortion can be charged with a felony that has a maximum term of imprisonment of 10 years. And of course, they leave the definition of assists very vague, right? So it could include giving gas money or giving information, or all of these things are yet to be tested in court. But it essentially, you can imagine that it's trying to undermine any support that minors would have for getting the services that they're seeking. Tennessee now has a bill, and has passed a bill, and a few others are introducing these bills as well. And there is a fear that that this won't stop with minors. We often see that restrictive policies start with minors because they have fewer rights to begin with, but then that can be used as a precedent to extend to other populations and other circumstances. Another barrier that adolescents face is forced parental involvement requirements. So these are laws that require that a parent either consent or be notified, sometimes it's both parents, prior to the abortion. And I want to talk about this a little bit because on the face of it, it sounds like, well, you know, we would want the parents there to support the adolescents. And this was actually an issue when Michigan passed our reproductive health amendment just a couple years ago. This was an issue that came up. Actually, the forced parental involvement requirement is still there in the Michigan new amendment. And we see this happening in many states, that states are exempting minors from the protections for abortion that they're introducing for everyone else. But what we know is that the majority of adolescents, when they seek an abortion, do involve either a parent or a supportive adult. Not every adolescent has a parent, or it has a parent as a primary support. But the majority of adolescents are already involving adults. Those who aren't will cite either danger to themselves or logistical impediments. So for example, I worked in Texas for 7 years. Many adolescents have parents who are still in Mexico who can't come sign paperwork, right? So, or parental incarceration or estrangement from parents, but you have, a guardian, not a legal guardian, you have someone, but they're not allowed to consent. So most of the time, those are the situations where adolescents don't have parental consent. And what we see is that these laws are associated with delays in care. So the abortions are done later. Often maybe a procedural abortion is necessary instead of a medication abortion. And then we see increased birth rates in states that have these as well, perhaps due to adolescents who weren't able to access abortion. There is it's no longer a requirement because it was reliant on the Roe precedent, but there is a procedure that exists in some states still called judicial bypass, where an adolescent who by definition doesn't have parent support can go in front of a judge and ask for this to be bypassed. The judges, which I'll talk about later, are asked to judge the maturity of the adolescent, but they're not giving guidelines on how to do so. This is complicated. Many youth don't know it exists. It's often traumatic to have to plead in front of a judge when you're young, when you're vulnerable, and it also is associated with delays in care. So there are only 14 states that allow minors to access abortion without parental consent or notification. Michigan is not one, although I happen to know that there will be a bill introduced to try and get rid of that requirement in Michigan, add that to the amendment that was passed recently. And so this is a report that Human Rights Watch and Planned Parenthood and several other Michigan-based organizations put out about the reasons why the forced parental consent law hurts young people. And so we're hoping that we see in future legislative sessions that can be removed. All right, and then additional barriers that adolescents face. One is limited information. So by nature of being younger, having had less exposure to the world, they have less information about reputable sources for abortion care. And we know that fewer than 50% of our high schoolers are receiving comprehensive sex ed, and few of those curricula include anything about abortion. So adolescents have limited information. Increasingly, it's unclear what information physicians are allowed to give in banned states, and many are erring on the side of not giving information at all because they're concerned about their own, that they may get in trouble. Cost, as we've talked about, is a barrier for adolescents, and that adolescents experience greater financial barriers. They usually don't have independent sources of income. And then telehealth, which is another avenue by which people are accessing medication abortion, is banned in some states for minors, and then some providers are not willing to do it even in states where it's not banned just because they are nervous about it. So even in states where abortion access is protected, adolescents are differentially impacted by the laws that are on the books. There are many laws that increase waiting times and increase barriers for everyone, but disproportionately impact young people, including those that have mandated waiting periods. So here in Michigan, we have a mandatory 24-hour waiting period between initial appointment and procedure, gestational age limits. So adolescents realize they're pregnant later, typically, due to many reasons, but so they often report later and may be more likely to be impacted by gestational limits. The mandatory ultrasound, which requires multiple appointments, which increases logistical barriers, and in-person requirements, again, because of all the logistical barriers. So this is my postdoc, Naomi Thyden. This is a project she has under review. This is a systematic review of studies that have looked at what are the barriers to abortion among adolescents. So the majority of studies that looked at this found that legal barriers were the major barrier, but those logistical barriers we've been discussing were another pressure from parents either to do it or not to do it, sort of either way, pressure to make a different decision than what they were making, pressure from their partner, and a lack of information. So we see that there's a lot of barriers. And with that, I'd like to shift to contraception. So this is our most recent data. This is from the YRBS. And this shows what we're seeing in terms of contraceptive use the last time you had sex, and this is among high school students. So on the left, we have condom, blue is male, orange is female, and gray is the total. And so we see about 58% of male, and apologies for the male-female dyad here. These are the way that it's still currently measured in YRBS. So about 58% of male and 46% of female are reporting condom use at last sex, but dual use, which is what pediatricians and medical professionals are recommending, sits right at about 10%. So I will say these are improvements historically, but we're still at suboptimal rates of contraceptive use and use of effective hormonal birth control. And then some general trends. So we are seeing increases in use of any method at last sex, increases in use of the highly effective methods, so the IUDs and implants. We do have a decrease in condom use happening across time, and as you might expect, corresponding increases in STI rates. And there's a whole active body of research trying to untangle the reasons why we're seeing that. One important source of contraception, if you are an adolescent, is a clinic or a provider that is funded by Title X. Title X is a federal funding stream. It's fully the Title X of the Public Health Service Act. So this came in under President Nixon, and it is federal funding for a broad range of services. So contraception is services and supplies, but also breast and cervical cancer screenings, STI testing, education and treatment. And so this was created as a safety net source of these services for people who could not pay or for people who needed confidential care for any reason. So this has historically been a very important source of confidential care for adolescents who may not be involving their parents in their care. Yeah, I think we covered that. And so there is a case, an ongoing case that has targeted Title X, and it originates in Texas, my previous home state, and it's Deanne W. Becerra. So we have a father who has brought the suit forward and said that parents have a constitutional right to direct the upbringing of their children, and the federal government is subverting this constitutional and statutory right in the Title X program, and in violation of the Texas statute that requires parental consent. So Texas does have a state statute requiring parental consent for contraception that applies to all funding sources except Title X, because Title X was a federal funding source. So Title X clinics were the only place in Texas where a teen could get confidential services. So this was, it went to the Texas Northern District Court. For anyone who's following the news, this name Matthew Kaczmarek is one that we hear a lot. It's common to bring anti-abortion, anti-contraception lawsuits in front of him. He has been friendly to those lawsuits. So he did rule in favor of the plaintiffs, saying that in this case, the Texas state law overrules the federal law, which I haven't met a lawyer who agrees with that, but that was the ruling. And so that stood in Texas. It was appealed to the Fifth Circuit. It was upheld in the Fifth Circuit. And so it does stand in Texas. So folks who might normally challenge this at the appeals court level are nervous to take it to the Supreme Court, because they are nervous that if they lost, this would now become precedent that impacted all states. And so what I had heard was that they were maybe not going to challenge the appeals court ruling. But then Texas decided to take it a step forward and say, we're going to sue the Biden administration and say that they're violating the Biden administration by continuing to provide services in other states is violating this federal ruling that they got at the Fifth Circuit of Appeals by continuing to administer confidential care through Title X. So we'll see. That is pending, but they're attempting to extend the decision beyond Texas. And again, this starts with minors, but it would impact all of the funding and could impact anyone who benefits from this funding. And I think I had over 300,000 minors per year are served by this, but millions of Americans are served by this every year. And so it's perhaps not a surprise that more young people are choosing permanent sterilization after Dobbs than they were before. So we have an ongoing study under review on this. And so these are data from IQVIA, which are very close to universal records of insurance claims of procedures that were done. And so these are, this is 2022, and give me a minute, let me walk you through this. So this is percent change from the corresponding month from 2021 to 2022. And then the months on the bottom are months in 2022. And the dotted line, we have marked May, because although the decision was in June, you probably recall that the decision was leaked in May. And so many of the reactions began in May. So we've dotted May there. And then blue are 19 to 26-year-olds, red are 27 to 44-year-olds. It's very atypical. Only for medical necessity would someone under 18 be sterilized, and then the data come packaged as 19 to 26, so we don't have 18-year-olds here. But what you can see is that the blue line, the younger people, have higher percent change, so higher increases in the number of, this is tubal sterilizations. I'll show you vasectomies in a moment. So we're seeing after the leak and then after the decision, we're seeing a pretty dramatic increase in a percent change. So that's tubals. This is vasectomies. And again, we're seeing that it's driven by the younger people. So 19 to 26-year-olds are choosing permanent sterilization in the wake of this decision. And then this is by state policy. So I'll walk you through this one as well. So red are vasectomy, blue are tubal sterilizations, and then solid lines are states that were deemed at the time of the leak likely to ban. And that essentially mapped onto the states that did ban. And so this was deemed by the Guttmacher Institute, who are pretty good forecasters of this thing. So that was sort of the best public knowledge of which states were going to ban. And you can see that in states that were likely to ban, so solid lines, so solid blue, solid red, we had higher rates of permanent sterilization than in states that were not likely to ban. So it seems as though this maybe was anticipatory of living in a state that was likely to introduce an abortion ban, and that tubal sterilizations, there was a rise in vasectomies, but lots of tubal sterilizations. And so what do we know about what has changed post-Dobbs and how this is impacting adolescent health? Well, I just told you about people choosing sterilization. I recently wrote a commentary in The Conversation, which is a really great outlet. I really enjoyed working with them and would encourage all of you to consider working with them. So Michigan's a founding partner, and they're essentially in a publication, an online publication that helps scholars put your work out in publicly digestible form. So here I made a few points about how I think that abortion bans are changing the experience of being young in America. So I absolutely talked about contraception and opting for sterilization, but we're certainly seeing in terms of voting and what's driving voting, that reproductive rights are very much driving voting patterns, both for those who are in favor and those who are opposed to expanding reproductive rights. I won't talk about mental health today, but we're absolutely seeing signs that mental health is being negatively impacted among young people by abortion bans and by fears that there's more to come. And then lots of career decisions and where to live decisions being based on what sorts of rights a state has. So where should I train for medical school? Where should I go to college? What job should I take? We're seeing data coming in that those are all being driven and that young people are less likely to want to live in a state with restrictive rights. So we had to act quickly. Things are still happening quickly, but in the wake of Dobbs, things were happening very quickly. And so we were lucky that there is a great panel that is held by the Department of Family Medicine here. It's called My Voice. So it's a panel of young people. It is very diverse and close to nationally representative, not quite nationally representative, but very diverse, 49 states. And they, every week, text the young people. These are 14 to 24-year-olds who sit on their panel. They send them a qualitative survey by text message once a week about ongoing current events. And so we were able to get on their docket for the week after the leak, the week after the decision, and then a couple months out after the decision to ask young people what they knew about Dobbs, how they were feeling about it, what they were seeing around them, to try and understand how this was impacting young people in the immediate, because we knew that data were going to take a little while to come out. And then we did add a fourth wave this spring, and we're looking at impacts on contraception and how they're thinking about contraception at this point. So the racial ethnic breakdown is diverse, as is the gender breakdown. We were asking about knowledge and awareness, opinions, information sources, so where they were learning about this, and what resource needs they might have if they or someone they knew were seeking abortion, and then contraception. So our first finding that I felt like it was important to just put out there, given the attacks that we have on adolescents' rights, were that adolescents are aware of what's happening. So this survey was fielded May 20th, so 18 days after the leaked opinion. We found that 89% of 14 to 24-year-olds, we just said, you know, the Supreme Court is thinking about changing abortion, right? A very vague prompt, and they were able to identify what was going on, so they were aware of what was happening. And then of 68% of them were opposed to the changes, and they expressed anger, fear, sadness. So we absolutely had young people who were supportive of these changes as well, and said this is the right thing to do, and had very strong beliefs in that direction. But these are some of the texts that we received. So this was in response to, how do you feel about the potential changes to abortion access? Horrible, abortion is healthcare and should be accessible to everyone. I don't agree with it whatsoever, because people should be able to choose. I fear that these changes are only a precursor to more strict laws regarding contraception and healthcare. I fear for the rights and bodies of those like me and those who are less fortunate. And I should have put an oppositional quote on here. An illustrative one is, I fully agree with this because abortion is murder. So we did receive those comments as well. A bright spot in the contraceptive landscape is that many of you hopefully have heard that the FDA has approved an over-the-counter birth control option. It's called O-Pill. Look for it. It's at CVS, Target, all around Ann Arbor. It's for sale and it's available. It's a progestin-only pill. Oh, I had to include, so this is story time. This is on the 63rd anniversary of the original approval of the pill itself. The FDA heard, and the Scientific Advisory Committee approved the case for O-Pill to be available over the counter. And one major consideration that they had before them was, should there be any sorts of age restrictions on who can purchase the product? And so I was brought in by the manufacturer, along with my colleague who's a pediatrician, to work with them on the case of, is this appropriate for young people? Can young people make decisions about using an over-the-counter method? Can they properly interpret a label? Can they use it appropriately? Can they seek help if needed? And then what would be the public health potential implications of this? And so, of course, we made an evidence-based case that adolescents are capable of making these decisions, and the medical community and the public health community were united that this should be allowed for minors to purchase. And so this was the moment that we got our unanimous vote that yes, it should be available over the counter with no age restrictions. And this was really historic. So prior, the morning after pill had come before the FDA, and they had made it available over the counter, but had put age restrictions on it, and really introduced barriers for a lot of folks who don't have IDs, folks who didn't have their IDs with them. It introduced a lot of opportunities to discriminate against folks. So age restrictions actually introduced quite a few barriers. So I think this was the right decision by the FDA, and it's now available for young people to purchase. The question is, do they know it's there? Will they purchase it? Is $19.99 a month doable for adolescents? So there's a lot of ongoing research about that and how much of an option this will be for adolescents. But we know there are 4.5 million sexually active adolescents in the country, and so this is a new accessible option for contraception for them that will not be impacted by state restrictive policies that may come down the line. Yep. Okay, and then I wanted to emphasize that a big part of the FDA approval of OPIL was that there was a youth-empowered youth organizing movement that I was not a part of, but that I very much admired. So young people across the country were involved in educating young people, in getting young people engaged through social media, making the case, gathering young people's stories about how they had struggled to access contraception, and demonstrating to the medical community, to the scientific advisory community, just how powerful this would be for young people. They testified at the hearing, and every person on the scientific advisory committee stated how moved they were by the young people and the really incredible case they were able to make for their right to have control over their own sexual health. Okay, so now going back to abortion and maturity. So I had alluded to this earlier, but so youth can go in front of a judge. They can ask for a judicial override of the parental involvement requirement. So this was a case in Florida, a 16-year-old. In her case, she was estranged from her parents. She had a guardian. The guardian was not allowed to provide consent. So she went before the judge. And the judge said she was not sufficiently mature. The primary thing that he cited for this was her GPA. And I'm a developmental psychologist, and maturity is hard to measure, but I don't think we would say it correlates much with GPA. And the problem is just there aren't guidelines, and so judges are making any sort of decision based on their judgment. So what we did recently is I'm a developmental psychologist. I've done work in developmental neuroscience and decision-making among adolescents. So myself, my colleague Emily Best, who's a lawyer at University of Chicago, and Laura Ray Lake, who studies adolescent voting at UCLA, dove into the developmental neuroscience research to think about autonomy rights and in particular reproductive and voting rights, and think about what do we know about decision-making, about quote-unquote maturity at a neuroscientific level. And the reason we went to the neuroscience is that how many of you have ever heard the brain isn't mature until you're 25? Right? We've all heard that at this point. What does that mean? Well, it is actually being used to try to restrict rights of young people. So an early presidential candidate who's no longer a candidate, but Vivek Ramaswamy said, well, maybe voting should start at age 25. We've certainly seen calls for rights to be restricted up until the age of 25, relying on this neuroscience evidence. And that is certainly not the interpretation that the scientists themselves have of the neuroscience. And so what we did here, just as background, neuroscience has been used in the past, particularly in the criminal justice sphere. And so we had a Supreme Court ruling in 2005 in Roper v. Simmons, where they ruled that the death penalty for minors is unconstitutional. This was largely considered to be a victory by the advocates and by the psychologists and the neuroscientists who were working on this. Unfortunately, what made it into the Supreme Court ruling was not this incredibly nuanced and sophisticated neuroscience that had been presented, but a pretty abbreviated characterization of adolescents saying that they lack maturity and that they have an underdeveloped sense of responsibility, which often leads to impetuous and ill-considered actions and decisions. I think the psychologist argued it a bit more subtly than that, but that's what we got in the ruling. And then we got in 2010, Graham versus Florida, life without parole for minors is unconstitutional, again considered a victory in criminal justice. However, we had these very reductive applications of early neuroimaging. So another thing you may have heard about adolescents is they're all gas pedal, no brake pedal, right? They're all go, no stop. And of course, it's somewhere in the gray, right? So sometimes adolescents, we know, can be emotionally driven, particularly in peer situations, particularly in high stakes situations, momentary situations, but they're not like that all of the time. And so what does this mean for other rights? If in a criminal justice context, we've ruled that adolescents shouldn't be punished in the way that adults still are, right? Life without parole and the death penalty are still available for adults. What does this mean for reproductive rights and voting and other autonomy rights? So we argued a few things. One, there's a broad consensus in the developmental literature, including some of my work, that there are at least two types of decision-making, reasoned and reactive. So reactive decisions are those that you make in the moment, in a split second, right? Somebody punches you, you punch them back. Or you're driving a car and you hit the gas instead of the brake, or right, split second. And those in experimental evidence have absolutely been shown to be the circumstances under which the adolescent brain performs less like an adult, right? More leaning toward risky situations. However, reasoned decisions are those that you have time to make. You are able to gather information, you're able to seek decisional support, you're able to weigh pros and cons, and that we know that adolescents by about age 14, 15, 16, depending on the protocol you put them through, perform the same as adults in these decision-making contexts. And they actually are somewhat self-aware that they are new decision makers, and so they spend more time getting information. They think harder, they weigh pros and cons harder. Adults, we think we know ourselves in the world, so we tend to make our decisions quicker. So adolescents will actually spend more time and sort of overcompensate on these decisions. And so we argued that abortion and contraception, by definition, are reasoned decisions. You have to have appointments, you have to talk to someone, you have to know that they exist, so you have to have access to some information, you have to identify that this is something that you want, so you've thought about your situation and why this would be an appropriate action for you to take. So by definition, these are reasoned decisions. And we also showed that in neuroscience, we are much less likely to be thinking about individual structures. So 20 years ago, we were talking about the amygdala as the emotion center. We don't do that anymore. We talk about entire systems of the brain working together with other systems and structures. And we know that there's much more sort of gray and much more heterogeneity than we had originally presented it as. And then there's tremendous behavioral evidence showing that adolescents can make specific reproductive health decisions. So they can comprehend package labeling on emergency contraception, for example, on medication abortion drugs, and on Opill. That publication is coming. They can self-assess the gestational duration of their pregnancy, which is something that you would need to do if, for example, you were seeking medication abortion by telehealth. They've shown capacity in medical decision-making about hormonal contraception dispensed in a pharmacy setting. And then finally, we say that we have to think about human rights here. So reproductive justice, the law, medicine are all really relying on human rights as one part of a framework to consider how to legislate or how to think about these decisions. And so absent kind of stark evidence that adolescents can't do this, a human rights perspective would argue that we should afford rights until we can see that they are not deserved. Okay, and then some future directions, so things that we are pointing out and some directions that we would like to take. So one of the several hats that I wear is I direct a team science research coalition called Youth Reproductive Equity. We're a national research network. We're very interdisciplinary. You see our disciplines there. And our goal is to produce and translate high quality research on adolescent and young adult sexual and reproductive health. So we have done things like immediately post-Dobbs, we tried to get messages out to a clinical community about what the needs of young patients were going to be. So my colleague Tracy Wilkinson wrote this piece in JAMA Pediatrics about considerations for pediatricians now working in the post-Roe landscape. My colleague Annie Hoops wrote for adolescent medicine providers. I told you about, this is one of our op-eds. We took every media request that we got because what we noticed immediately post-Dobbs is that people were making a list of groups that they expected to be disproportionately impacted by Dobbs, and they were all, absolutely right. So people of color, people living in banned states, people of low income, people with disabilities, etc. But that adolescents and minors weren't on that list, and so we wanted to elevate the reason why we were particularly concerned about adolescents. And then I've told you, as we've dove into the literature and as we've been trying to do more of this research ourselves, we've hit a lot of data limitations. So we got a grant to support us to do this research agenda. It's called Adolescents Post-Dobbs, a policy-driven research agenda for minor adolescents and abortion. Because minors are underrepresented. Lack of data is an equity issue, and it's also a liability. It's a scientific liability. How can we have scientifically rigorous studies if we're systematically excluding some members of the population? It affords non-evidence-based policy, because how can you have evidence-based policy without evidence? And it took way too much of my life and my time, so I would love if you downloaded it there at youthreproequity.org/research agenda. There's a webinar, there's a fact sheet, so please check it out, but I'll tell you a bit about it. So our goals were to describe the need for research on minors, so why is this important? We did a full policy review of policies that are impacting minors' abortion. We laid out a clear and actionable plan for generating and translating rigorous research. And then we made the case that it's not just about abortion or people who have abortions. I hope that I've shown you already through what I've talked about. We're seeing population level impacts of this. People who are not pregnant are seeking sterilization or are experiencing mental health impacts or are changing where they want to live and work because of these reforms. So we did an expert consensus panel. We had young people, of course, researchers, clinicians, leaders of nonprofit and reproductive justice organizations, and legal and policy experts. We covered both protective and restrictive policies, those that are specific to minors and those that impact all ages. So if you're doing policy research, we pointed you to some. There are some interesting ones that even I had not heard of. And then we talk about both the direct and the indirect impacts. So the direct impacts are on people who become pregnant and those who support them. And one thing that we point out is that we lack adequate data to quantify and describe minors' abortion experiences. When we are collecting data, the federal and state surveillance are incomplete, or they aren't stratified to show us minors separately. The studies that are ongoing about abortion patients usually have very few or often no minors included in them. And then the real-time data collections like the We Count from Society of Family Planning aren't collecting age or race or many other key stratification variables. So we know very little about subgroups. This directly impacts pregnant minors. So we would love to see an expansion of studies that have traditionally focused on adults and abortion to encompass minors, and then tailoring some studies specifically focused on minors to capture the unique and disproportionate impacts and barriers that they're experiencing. And then to capture the indirect impacts on the total population. So those ongoing and upcoming population representative studies can be very helpful in this regard to capture context of adolescents' lives as abortion access is changing, learn about minors' SRH and abortion-related knowledge, attitudes, and behaviors. So we give recommendations, and I'd be happy to talk about to anyone about how to maximize the utility of your data, even if you don't think you're doing an abortion study, for us understanding adolescents changing lives as abortion policies are changing around them. So I would love to have that conversation. And then just to tease, this is our new study that we're very excited about. So as we attempted to do some work on the impacts of policies, I discovered that there is no longitudinal database of states' policies on abortion, contraception, and of course we're interested in sex ed, that would allow us to do the types of quasi-causal work that we would like to do on what the impacts of policy changes are. So there are a number of groups that will tell you current up to the minute policies. New York Times is doing it, Kaiser is doing it, but if you want an archive to map onto your existing data, and I just noticed a typo, that should say 2028, not 2018. We are going to go post-Dobbs. So we are going to capture all state policies on contraception, abortion, and sex ed and minors' ability to consent from 1973, the year of Roe, to 2028, the year that our grant ends, but we hope to keep it going further than that. So we know that states are the center of gravity for SRH policy at this point, and there's tremendous variation. So we want to capture that. There is a need for transparency and documentation, both to enable anti-racist research, but also just rigorous policy research, and support timely evidence-based advocacy as well as education. So many educators have come to me asking for this. So we're using an approach that combines legal and epidemiology, plus sexual and reproductive health, plus data science. We'll create a comprehensive longitudinal data archive of over 150 state policies over the 55-year period over the 51 states and municipalities. It'll be a publicly available data dashboard. We're hoping to get it up prior to 2028. I'm working very hard on that with an interactive interface. We are actually working with researchers to optimize the utility of this for researchers. And so if you want to be in our study, let us know. You can come test the data. And we also hope to work with many of you to merge with outcomes data that many of you produce so that we could afford analyses of that. All right, acknowledgements, funding from NICHD, William T. Grant, Society of Family Planning, and my prior employer, University of Illinois, Chicago. And I'm happy to take questions. Thank you so much. I said, I teach. I can stand in silence all day.
Thank you.
Okay, so I have been seeing certain studies about how for Gen Z, there's been this gap sort of with ideologies between people who identify as male and people who identify as female, where Gen Z men tend to be getting more conservative as Gen Z women and non-men tend to be more progressive.
Mhm.
I was wondering if, I know that this is probably too early to tell, but I was wondering if those divides ideologically have been showing up like in this data. Are they, could it impact this in some way to have that kind of discrepancy in viewpoints?
We don't have much data that speak to that. So the My Voice study that we did, where we had 800 young people texting us, we did look for gender differences and didn't see any. We also looked for differences across state, restrictive and non-restrictive state, and that was really interesting. We didn't see patterns that young people's opinions were varying there. It's not, I would want to see much more data though, and those were very early reactions, right? So we have to see how people's opinions change. This is really evolving as the election cycle plays out. Yeah, but in general, the majority of Gen Z are supportive of expanding reproductive rights. And I haven't seen giant gender differences, but it's something to really pay attention to. Yeah.
Thank you, Julie. Question related to the database that you're setting up. I've in the past been involved in similar work with drug policy databases and online interaction interfaces. I'm curious as to if you're going to try and get at local policy, prosecutorial decisions, judicial decisions, something like that, because at least with drug policy, we found that the big linchpin was the prosecutor as to whether or not they were going to prosecute, thus whether the police were going to do it and where the judge was going to make a decision. So I'm just curious as to if you're going to try and do anything at the slightly lower than state level. I know that's super complex what you're already trying to do, but I'm curious.
So in this grant, we won't get into enforcement. So for example, there are laws that criminalize pregnancy, right? So pregnant, and I actually have a postdoc that I'm mentoring who's very interested in that. And so that's where you get into enforcement. There may be laws on the books that no one ever prosecutes, or that many people prosecute, or laws that they sort of creatively interpret to use to prosecute. So we will not be getting into individual cases of enforcement. What we will get into is any sort of appeal or judicial stay that would impact the state level policy. And there's a lot of that happening. So we have policies that sort of go into and out of effect at the state level, depending on what type of litigation is pending, and we will get that. That's actually really important because there are laws that have been on the books that have been stayed for 20 years in some cases, right? And so the case is just pending forever. So they're not actually impacting anyone. And that in previous research has not usually been taken into account. And so people are not doing the very detailed type of causal analyses we would like to see. So we are going to get effectiveness dates and when they're impacted by litigation at the state level. Local level enforcement, totally interesting, would need another grant. Yes.
Hi, I don't know if you have information on this, but I'm wondering if you've seen changes in specifically adolescent sentiment regarding the hormonal birth control pill, and if there's been changes, because I feel like even among peers and people who are like believe in reproductive justice, there's like individual fear around the pill, and there's been increasing discussion regarding its like link to causing cancer. And if that's been something that's looked at, and if there's any public health strategies to address this concern.
Yeah, so I personally have not done the studies, but within YRE, we have a couple groups that have done, for example, analyses of TikTok videos where this is being discussed. So yes, on TikTok, there's a very strong anti-hormonal contraception crowd among young folks. And so they analyzed kind of the top let's say 50, I don't know how many videos and their content on contraception, and found that yes, this is happening. And so I would say that my colleagues who are involved with American Academy of Pediatrics, or we're trying to get Society of Family Planning to put out guidelines, certainly the medical guidelines are still saying that it is safe and that we haven't seen demonstrated links to most of those outcomes. And then when we were making the case for O-pill, which is a progestin-only pill, so it has only one hormone, not two, we had to show very clearly that POPs have almost no associations with those outcomes. So I think trying to differentiate, there's always new formulations. And so I think there's a lot of trying to both study them and show scientifically that those impacts aren't being seen. But yes, I think it's a cultural phenomenon that is happening. I would love to see some of the professional organizations get on board with, and there are AAPs on TikTok as well. It's happening. It's playing out like a lot of other things. Yes. Deva.
With these policies changing so much, can you say anything about what's going on in Michigan with adolescent access to contraception or abortion?
Well, so one thing I pointed out was, so Michigan did pass their reproductive rights constitutional amendment, right? And I wasn't living in Michigan yet when it was happening, but as originally written, it did remove the parental involvement requirements for minors to access abortion. There was some controversy around that. There were TV ads that were run, for example, and there was fear that it might not pass if it had the exemption of parental consent for minors. And so we've seen this happen in multiple states, and we don't actually know that it's true that it wouldn't pass with that provision in there, but it is an easy thing to make an attack ad about, kind of a young girl crying. And, I sometimes I put the ads in my talk, but so we did see that the choice was to pass the amendment without the minor provision. When we did our expert consensus report, this is a pattern. We see this a lot, where minors are a concession that's often made in order to make sure that they pass the initial reform. And then sometimes they come back to minors and sometimes they don't, right? And so we're just worried about that being a concession and what that is going to mean both for minors, but in terms of also what sorts of precedents are being set and how those could be expanded to other groups.
This is just a more general question from like the data that you presented at the beginning. So you talked about the importance of having to actually have data on these kids, but I'm curious what the conversations are like among all of you doing this work about how you are going to collect that data in these states where there are bans and people maybe don't want to talk to you.
It's a huge concern. The problem, as I understand it, is less that people don't want to talk to you. So we still have willing participants, but it's more about data privacy and what are the policies of the companies who are holding our data. So for example, it turns out Qualtrics can't guarantee total data privacy. So many have moved away from Qualtrics, for example, and not to throw Qualtrics, there's a lot. If you check the privacy guidelines of many of the softwares and many, so that a lot of concern is there. And then also concern about any liability, like if someone were to disclose something, which is always an IRB concern. So our group actually, YRE, is working on IRB guidelines because the number one barrier that is cited to us by our researcher peers about why they're not including minors in their studies is, oh, my IRB won't let me. That's not usually true, but IRBs are incredibly rigorous in reviewing these studies when they're thinking about a minor. When minors participate in our studies, we would like to not have to have parental consent for the same reasons I've listed about the limitations of parental consent for accessing services. And so IRBs are very conservative about a minor coming in, talking with you about a stigmatized behavior, about private things. It is absolutely possible to do it, and those of us who are trained in working with adolescents know how to do it. So we're working with Society of Family Planning to create a research practice guideline, which is their sort of professional guidelines on how to do this, and working grants in progress to work with IRBs and with HHS to further specify, because we're seeing that local IRBs are much more conservative than the actual HHS guidelines. So we're trying to reconcile some of that, provide guidance. We do a lot of just professional development with our colleagues. So I'm hosting a pre-conference in a couple weeks where we actually have a couple dozen researchers, and we'll be workshopping your protocol, how to work with IRB, how to do recruitment, all the barriers that people are encountering. Yeah, but I think data privacy and security have been the biggest concerns, and the listservs are constantly sort of lighting up with, how are you handling this? What are you doing with this? Yeah.
Thank you so much. I think we're about out of time, and so we'll leave it there. Thank you again, Dr. Maslowsky, and thank you for everyone for coming.